So thank you, Dr. Gagan. As Dr. Sandeep and Dr. Rashad have already described the, the main idea of amniotic membrane and why it is so useful, I will skip these slides which basically emphasize that amniotic membrane is basically helps in cell differentiation, prevents cell death, and elongates the cell life. It's important one of the most important characteristic for which it is used in reconstruction is because one, it is one of the thickest basement membranes, so it gives you a better template or a substrate while being used for reconstruction. And second, it also reduces the scarring. This is especially important in conditions like symblepharon, chemical injuries, where we know that there is a lot of fibrovascular scarring which is likely to come back again after the surgery. So, as Dr. Rashad said, that it's not the epithelial viability which is important. It's basically the membrane is being used as a matrix or a substrate, and therefore putting which side up or down is not that important. Coming to ocular surface reconstruction, so the objectives of ocular surface reconstruction are importantly to establish the epithelial cover that prevents stromal melting. It also limits the scarring and also limits inflammation. The common indications in which you would use ocular surface reconstruction is, apart from chemical injury and Steven Johnson's, when you're removing a large area of conjunctiva. This could be a conjunctival tumor or a large atypical or double-headed pterygium, and also where you expect there is recalcitrant scarring like a recurrent pterygium, a symblepharon release with fornix formation to adjust the prose lens, post-chemical injury, and even in contracted socket. Now, it's important to understand that amniotic membrane is not a complete solution. There is still a very high rate of failure in amniotic membrane grafting, especially when there is a significant stem cell deficiency. So large areas of conjunctival loss also, along with stem cell deficiency, will end up with a failure rate of 44%. And in spite of some residual stem cell deficiency, if the area of resection is very large, again the failure rates can be high and you may end up doing a repeat procedure. So the simple indications we described, that if you have to remove a large tumor, so the large bare area is covered with amniotic membrane, and I'll skip that video because it was just the basic video how to place an amniotic membrane. I would like to discuss the role of using slat along with amniotic membrane grafting in conjunctival tumors or in stem cell where there is a large area of stem cell deficiency. As you can see, this large tumor occupies almost the whole of the ocular surface, and to remove it, it's going to leave behind a large area of deficit. So the options here are, one, we can use an amniotic membrane, a large size amniotic membrane, and perhaps take out a slight small amount of conjunctival tissue from the other eye, or we can use the slat again from the other eye because there is also associated stem cell deficiency here. In case of OSSN excision, it's important to maintain the no-touch technique. While sending it for histopathology, it's important to mark the areas so that the orientation is right. Because in these tumors, there is also cryo which is being done on the margins, so the ability of conjunctiva to heal back is slow, and therefore again amniotic membrane becomes important. Here what you see is a mini slat being done, is a proper slat being done in this area because the amount of dissection is large and almost there is a complete stem cell loss. Now, acute injury, Dr. Rashad has covered very well, and it is important that in acute stage, role of amniotic membrane is basically to reduce the inflammation, prevent the chances of melt, promote healing, whatever it may be conjunctival painus or it may be an epithelial healing. Studies have shown that amniotic membrane is extremely important in acute Stevens-Johnson syndrome patients, especially in grade 2 and 3, where it greatly reduces the probability of persistent epithelial defects in the cornea and also associated stromal melt. However, an amniotic membrane cannot prevent a stem cell deficiency. That has to be covered by, that is basically the role of systemic immunosuppression, which is very important in the early stage of Stevens-Johnson's. Now, looking at this clinical outcomes in the recently published report by the American Academy of Ophthalmology, it has shown that in moderate grade burns, that is Roper Hall grade 2 and 3 or Dua classification grade 3 and 4, amniotic membrane significantly improves corneal reepithelialization. However, there is no statistically significant difference in the improvement of visual acuity. This statement might give you an impression that then what is the role of amniotic membrane grafting in these patients? It is important to understand that reepithelialization, early reepithelialization provides faster healing for the patient, and then sequelae of chemical injury in the form of symboliform are also much less in these patients. So visual acuity is one parameter, but then the health of ocular surface is much better in patients who have had an amniotic membrane graft. And another thing that Dr. Rushad said, that in these patients in acute chemical burns, using an amniotic membrane greatly improves reducing uh, the invasion or the invasive pannus formation, and therefore it is much easier to remove the pannus in subsequent surgeries. The video that we are seeing here is basically an old an old case of chemical injury with a persistent limbal ischemia. And here we had put an inlay graft of amniotic membrane because there was underlying thinning of the sclera. And over that, a free conjunctival graft was made. Now, it is important, I wanted to show you this video because there is one step which is missing here, and perhaps that would have been to bring the tenons capsule to the margins of the limbus so that it brings along with it more vascularization and the limbal ischemia is also addressed. This is highlighted by this patient in which there is a large area of 360-degree scleral and limbal ischemia, and there are no blood vessels right up to 3 to 4 millimeters from the limbus. In this patient, tenoplasty was done and 360-degree coverage of tenons was provided to the limbus, which provided a much better vascularization and improved the chances of subsequent success for the subsequent surgeries. Similarly, multi-stage procedures are required in patients who have extensive ocular surface damage, when at the end of it you get more gratifying results. So, another important group of patients which benefit from amniotic membrane graft are patients who have a recurring pterygium. It is important that these patients have significant scarring. They have variable adhesions at different levels, so the dissection is going to be equally traumatic for these patients. You have to use more cautery because the chance of bleeding is more. Therefore, you actually enhance the chance of limbal stem cell deficiency in that area and also chances of scleral ischemia. As Dr. Rushad showed in this video, basically the amniotic membrane being used here was to reduce the subsequent chances of scarring and recurrence of this pterygium. So here we had basically used this as an inlay along with a conjunctival limbal autograft. This is the last video that I would like to show, and this is I'm going to play full. This shows again a recurrent pterygium, and here you can see that there are multiple levels of adhesions which can be seen. Even the eyelids are stuck onto the pterygium surface. This patient has a very dense fibrovascular tissue which is very invasive. These patients cannot be easily managed with an amniotic membrane because we know that by the time amniotic membrane would dissolve, that is maybe a matter of 1 to 2 weeks, there would still be an extensive amount of inflammation which will persist in the surface. These patients do very well with a mucous membrane graft. It helps you to also form the fornices and also prevents the chances of significant scarring, which is very, very likely after just an amniotic membrane graft. Once the mucous membrane has been done and fornix forming sutures have been placed, there is a mini slat which is being done, and it is once the amniotic membrane here is being used to cover the corneal surface, and also to provides you a template over which you would place the slat tissue. So amniotic membrane in alone may not be sufficient in patients who have very significant scarring, and it can at best being used as an adjunct uh, for that particular reconstruction that we are planning. So it's important to understand that presence of limbal and conjunctival stem cell is very vital to the success of ocular surface reconstruction. You should avoid patients with infected surface while planning a ocular surface reconstruction. Also, patients with severe loss of limbal stem cells, large tissue defects, and exposure on neurotrophic insults require additional care. So with that, I would summarize. Thank you.
Thank you. Thank you, Dr. Deepender. Just a question, you mentioned for scarring you would do an MMG. Any way that you would decide on the amount of scarring and when you take this decision, and do you combine SLET in all these cases, or when would you take and how would you take that decision?
So in a recurring pterygium, for example, especially when you are not the operating surgeon for the case before, then this is the first time you are operating. Your clinical judgment depends on two factors. One, while you are dissecting, how much is the plane, how much is the damage to the underlying scleral surface, how much is the dissection that you have to do. Also, to look at the health of the donor tissue. The conjunctival tissue, if it has been taken once before, you will have more fibrosis and scarring, and therefore the subsequent chances of survival of that conjunctival autograft will also be less. So in these patients, perhaps taking a little bit of extra limbal tissue gives you a better chance of corneal healing faster than the conjunctival healing, and therefore the chances of conjunctivalization spreading over the corneal surface is much less.
And in chemical injuries, even in milder injuries, would you suggest doing a amniotic membrane, or you would say medical management? And when do you decide on when you would actually put any MMG in those cases?
Sorry. I think in mild cases, amniotic membrane is not required. You can wait and see the response to steroids. Sometimes we are very hesitant to start steroids in the early first week, and that is where we lose the battle. So in mild to moderate, first you can give a 3 to 5 days interval and look at the inflammation, how it is being controlled with the help of steroids, and then decide. Especially if you see that the epithelial defect is not healing, there are signs of slowing down of healing, then again it's better to switch to amniotic membrane.
So, Dr. Deepender, so just another basic question. I think Dr. Sandeep had highlighted a few of the benefits of or the advantages or pathomorphological features of amniotic membrane being pluripotent, acts as a scaffold and everything. So, basically between you and Dr. Rashad, I think just want to ask that what are the factors which help you, decide or makes this the better biological than other like allograft or something like that? So what are the basic factors which makes amniotic membrane grafting or amniotic membrane per se a better biological tool in anterior segment pathologies?
So amniotic membrane is basically a template. Okay, it provides you an opportunity to cover the surface which is denuded right now, and you expect the body's healing response to cover it with its own epithelium. Whenever there is a situation that potential for the body to cover it with its own epithelium is poor, that is where you need a graft. This could be a conjunctival graft. If it is primarily a conjunctival healing issue. This could be a limbal graft when you expect that there is a limbal stem cell deficiency. Even a mucous membrane graft may be useful, especially when it's a bilateral condition or when there is extensive scarring. The only problem with mucous membrane grafting is the persistence of the reddish hue of the mucous membrane which lasts. But an additional advantage of mucous membrane graft is that it brings along with it minor salivary glands, and therefore there is better goblet cell density in these patients. That helps in subsequent dry eye issues which will come in these patients.
So AMG is kind of the first line of treatment, and then subsequently you have to see what to do next. It's your first opportunity to kind of heal the surface, let the surface heal on its own actually.